Okay, so this week we're talking about somatic symptom disorders, feeding and eating disorders, elimination disorders, and sleep-wake disorders. And Chris, you've got the summarized versions of these. You want to talk about what you have there?
Uh, well, I have the summarized versions and the sub summarized, but I think we can just start with somatic symptom disorder. Uh, Concern about one or more somatic symptoms leads the patient to express high level health anxiety by investing excessive time in healthcare or being excessively worried as to the seriousness of the symptom. So before I go into it, I think like this used to have a different name in the DSM-4, correct? Is that right, Dantley?
Yeah, and wasn't this like hypochondria? That's what I think of.
Yeah, yeah. I think it's
That's
Yes.
exactly
what you
what
would
I
typically
thought.
know as a hypochondriac. So basically, like, well, hypochondriac, I think we get into kind of later, but somatic symptom disorder, you actually have the physical pain. I think hypochondriac, you're just kind of making up. Uh,
You constantly think that you have something wrong with you.
yeah, yeah, yeah. We'll get into that a little later.
Yeah.
Um, so one of the things about the somatic symptom disorder is that, and this goes into like the fine print, the D's. So like duration. So they have to have the symptoms for 6 months, and there is no differential diagnosis in the DSM-5 according to this book. Somebody can prove me wrong, but it's stated that they would look into substance abuse, physical disorders, mood and anxiety disorders, psychotic or stress disorders, and dissociative disorders as potential differential disorders for this. Um, and then, of course, additional codes would be with predominant pain. So that'd be with patients who mainly complain of pain. And then there's a sub-diagnosis for this, actually, and then persistent. And then it goes into mild, moderate, severe. So considering the following behaviors related to seriousness of patient's symptoms: excessive thoughts, persistent high anxiety, excessive energy, time expended. So, based off what I just read, mild would be one of those behaviors if the pain is causing one of those. Moderate would be two plus, and then severe would be two plus plus with numerous somatic complaints. So, so that's basically like I wrote it in my notes. Like if somebody keeps having like a chronic pain and there's no physiological reason why they should be having it, like it just happens, something mental, something psychological is causing them to have a pain stressor, and there's nothing physiological about them. No X-rays show anything.
Hmm.
And I don't even think it necessarily has to go into pain because there's a separate one from pain. So I was trying to think like what could be some secondary like symptoms of somatic symptom disorder that you might experience other than just like the pain part. Like maybe it could be numbness. I don't know. Anybody got any ideas on that?
Well, and I think it can be a general like sense of I don't feel good and something is
Hmm.
wrong, right? But
Yeah,
there's
like
no
fatigue. Like for
right.
example, one of the girls that I was working with today, she was like, I've been so fatigued lately, and she was like, I feel like I have to go to the doctor, and she's like, I feel like there's something really wrong. And she got her lab work back, and it was just like her iron was low or something like that. I was like, that's easily fixable. But it was the fact that she was like freaking out, freaking herself out about it, that there was something really wrong when it was just fatigue.
And something notable that in this text that's not, I don't know if it's in DSM-5 or not. I don't have DSM-5 open right now, but it's found in 1% of all women, and it's not found. This disorder is not found in men a lot.
Actually, I made a note about that to talk about it because as a woman, um, when you go in and you explain things, I think sometimes my experience has been it gets kind of push away. I'm like, okay, maybe it's hormones and it's like like I have a actual thing happening here. Like I am feeling something, but I feel like as a woman, we don't get listened to maybe in the way that I would like to myself specifically. And Michaela, we're the only women in this group, so I don't know about your experience with that, but it's interesting to me that this happens more in women
Mm.
than men, and I do feel a little bit because of that, because I think it gets
Well,
discounted.
it's diagnosed more, so then that
Right.
opens up a whole different can of worms. Like,
Yeah.
and
Yeah,
then
I
we have
definitely
like the whole
agree.
non-reporting thing because the machismo, like how many men like have this, but then like, hey, I'm not going to report this phantom pain to my doctor because
Well,
it
yeah,
doesn't make any sense.
right.
Mhm.
And I'm not going to complain. So from a man's perspective of it, maybe like I'm not going to complain about it. It is, I'll suck it up, like whatever.
Yeah, the tough. Gotta
The
be
tough,
tough.
like, don't like fight it out or whatever. But then on the women's side of it, it's like, oh, well, you're sensitive. It's your hormones. It's your, are you just hungry? Like, and I'm
Are you
making a
about to
joke
start your
about
cycle?
that. Right. Are you on your cycle or at the end of it or
Are you
in,
pregnant?
right.
Yeah.
The
Yeah.
Yeah.
list goes on. Yeah.
I know there's quite a few studies that's especially prevalent in African American women. They always get like their pain ratings are always rated lower than any other intersection because of that. Like there's a stereotype that they're just being like the histrionics or they're being dramatic. So there's quite a few studies about how black women like that. So then you kind of have to be boisterous about it, but then when you are, you're deemed that you're being dramatic and they're often under prescribed pain medication.
Yep.
So one of the things I highlighted, kind of reading through this, uh, again, this is in the made easy version. So it says half or more of patients with SSD have anxiety and mood symptoms. There is an ever present danger that clinicians will diagnose an anxiety or mood disorder and ignore the underlying SSD. So, as a clinician, I think that's something to be, or hopefully we'll be clinicians one of these days. Like, are we just quick to rule out that they have an actual somatic symptom disorder just because they also have like anxiety and mood disorder, and we just want to lump it all into one thing? And like you're talking about, like we can just rule it. We can just say, oh, it's ant flows here, or something else is going on with women, and it could be easily translated to something else. So just something to keep in mind that it's seems like it's kind of under diagnosed if it falls into anxiety and mood disorder. They already
Yeah.
have that diagnosis, then you tend to miss this one.
Well, and I do think also like we prescribe stuff at such a rapid rate that it's like, what are you, what are you experiencing? Is it from life or is it side effects from, you know what I mean?
Yeah.
Mm-hmm.
From pharmaceuticals. So,
So the next one that it gets into is the illness anxiety disorder. Does anybody have anything on that before we get into the definition, or anybody have any takeaways?
Yeah, I think I'm looking at my notes. That's the previously called hypochondriacs or hypercondiasis or whatever in the DSM-4 was the
Yes, I believe so.
yeah, that's the one where it's like same thing. They have no somatic symptoms, but they have a preoccupation with like developing the illness. Like they're always afraid they're gonna get sick versus actually being sick at the time.
Mm.
I think you nailed it. Uh, I hate to just read all this craziness, but it says
and can I,
despite the absence of serious physical symptoms, the patient is in, inordinarily concerned about being ill. high anxiety coupled with low threshold for alarm yields reoccurring behaviors concerning health, such as seeking reassurance, checking over and over for physical signs. It said some patients will cope instead of going to hospital. So getting into the criteria, they have to have this symptom for over 6 months, although concerns may vary. So say I think I have cancer for like a month, and then I Google diagnose myself, and then I decide that I don't have cancer, I got something else. But like if they're 6 months in this cycle of constantly thinking something's wrong with them that's not, then the differential diagnosis gets into substance use and physical disorders, mood and anxiety disorders, psychotic stress disorders, body dysmorphic disorder, which I think we just had a case study on that, and somatic symptom disorder. So I guess you got to rule out the first one before you go to this one. And then there's also like a coding note, like there's the care seeking type and the care avoidant type. So there could be somebody that always thinks they're sick that is constantly going to doctors. And there could be people that always think they're sick, but then they just isolate and be like, oh, I'm going to die, whatever.
Yeah. Yeah, that's what one of our case studies was about too.
Yeah.
Was someone they're going to the doctor and they're not getting any diagnosis. Like there's nothing that's showing up as
Are you
anything
giving
being
us
wrong.
quiz notes right now?
Let us
Take the
jot
notes.
them down. I'm just kidding.
So then it goes into conversion disorder. So that is a patient's symptom or symptoms changes in sensory or voluntary motor functioning seem clinically inconsistent with any known medical illness. Anybody got any examples of that?
Can you say that again? Sorry.
Patient's symptom or symptoms changes in sensory and voluntary motor functioning seem clinically inconsistent with any known medical illness. So would that be like shaking, even though you don't have like Parkinson's or anything wrong with you, or no low sugar, or maybe like let me read into this a little bit.
What about like those like um, where people will have like pseudo seizures?
I heard like you're cutting out pretty bad, Aiden.
Aiden,
I
I
heard like
don't know. Yeah, okay. I didn't know if it was me.
Yeah, I didn't know if it was me either. I was like, is that just my computer?
We didn't get to hear what you said.
I heard pseudo seizures. Like,
Can you hear me now or no?
Yes.
yeah, that's much better.
Okay, sorry. At work, like the signal is really bad. I was saying, is this kind of hinting at like pseudo seizures? Would that be like an example?
Yeah, I think it gets into like if you get into, I was getting ready to read off that, but like a specify like a type of symptom, it goes into like weakness or paralysis with abnormal movement, uh, tremor, abnormal gait. Their swallowing symptoms, speech symptoms. Get into code F44.5. They can have uh, seizures with no known reason, and then anesthesia or sensory loss. That'd be like a numbness or
And they're not faked, right? Like they can't
yeah,
find
like they're.
faking. Like, and
It
to them,
actually said something about there must be positive supportive evidence. So if you rule out all physiological factors and they're still experiencing these things, and that's probably when you would start looking into this diagnosis. I don't know that I've ever seen it.
Me neither.
We're getting into the abnormal psychology field here. And then next it goes into psychological factors affecting other medical conditions. A physical symptom or illness is affected by the physiological or behavioral factor that precipitates, worsens, interferes with, or extends the patient's need for treatment. I'm not completely sure I understand what this is.
I saw one example that was like, if you have anxiety, it's going to make your asthma worse. So if you're already short of breath and then you have a panic attack, like it's going to make it worse.
Oh, okay.
That makes sense. Yeah.
So probably like high blood pressure and you have anxiety, then it's
Yeah,
like
yeah,
starts
that's
stacking.
It's gonna get worse. Yeah. That makes sense.
Yeah. And of course, they give case studies in this that we're not going to read through because that would take forever.
We have a lot
I'm
of
not even for sure we'll get through.
these for. Can we move on to Chris feeding and eating disorders? Or no? Or you have another?
You want to, now we're into like factitious disorder. I don't know if we need to dig into that. And then that goes right into like feeding and eating disorder.
I think for our time, can we move on to like the overview of feeding, unless anybody else had stuff to share on the
Yeah, I think.
Okay.
I mean, like I said, this is a reference guide and it's
Right.
a lot of information to digest.
Sure.
Anorexia nervosa. Anybody have any experience with that?
No, not directly. Is there an overview of like feeding and eating disorders? What you-
Well, if you go into the coding, Nate, let me read that. These patients are usually young women, eat so little that many look skeletal, yet remain fearful of obesity or weight gain, have the distorted self-perception that they are fat. It gets into duration, but where you're talking about, there's a binge eating purging type, which would be like binge eating and then vomiting. Which my sister had that type. She's a doctor now, by the way, but she still, I think, struggles with it. And then restricting type was where you're just basically not eating at all.
Yeah. Well, and so I will say this about like the overall of the eating and feeding disorders. I found that the food addiction versus substance abuse, how there were patterns of things like cravings and compulsive use and self-control, reward, that kind of thing that were connected, but they didn't have a lot of like substantial evidence to show that food was on the same kind of level as substance use disorder. And as someone in my own life, so I had a weight loss surgery in 2016. And so as someone who's always struggled with that, um, I was a little bit bothered by this information because it's like, yeah, I don't use XYZ. I don't use, illegal drugs, or I don't use even whatever legal drugs there are. But food is it's what I go to. Like when I'm stressed, I go to it. You know what I mean? Like that's what I go to. And And when I'm stressed, it's like I will eat an entire sleeve of cookies. Don't challenge me. You know what I mean? Like I'm just
Yeah. I find myself eating more whenever I'm just not having anything to do. I'm a very, like, I gotta get
bored.
up and go, go, go type of person
Okay.
because if I'm just sitting around and not really doing much or just, what they call bed rotting or something like
Right.
that, like, I will eat snacks on snacks. Like, I have to be doing something or like at
And
all
is
times to keep
that
my,
I,
difference, right? Isn't that the difference? And one of the differences, like, but between anorexia nervosa, binge eating, purging type, and then bulimia nervosa is kind of like what you're all saying. Like, it sounds like Denise was saying, it's like she's out of control when she's doing it, and you're just kind of like
yeah,
casually doing it. Not to put it out there, but like that's the difference in the DSM-5 is one, like you have to be eating a ton in a short amount of time with complete loss of control.
Right.
So
so
just
But I've also never like made myself vomit. You know what I mean? Like there's not that purging part of
gotcha.
it. It's
Yeah.
just
I
go on.
there was just a neuroscientist on Joe Rogan. I don't know if anybody watches Joe Rogan, but he got into like how everything's based on like endorphin rushes to like boost like phone addictions and eating addictions, and I think the biggest endorphin rush you can get is doing meth. So that's why it's like one of the highest addiction rates. But like I was like hunter gatherer types, if you were like hungry and you shot a deer or you found a tree or whatever, it would your brain would reward you and then like load you up with endorphins. So now we got all this stuff like readily at our fingertips. Like I can go on Facebook, see I got 10 likes. Maybe that makes me happy. I can eat a sleeve of cookies. Maybe that makes me happy.
shopping.
Yeah, go shopping. Like it all just
Mhm.
the dopamine like rush that you get from all that stuff. Um, like reinforces the behavior. So I think you're right on like eating disorders and stuff. It's another form of addiction. I mean, it is. And then there's cell phone addiction. There's gaming addictions, gambling
Yeah.
addictions. Like it's all hitting the same part of
Right.
the
They just
brain.
Right.
become used to that, like, type of routine, I guess you would say, like, binge eating a lot and then checking their weight excessively, and it just becomes like you have to do it.
Well, and so that was my point with this is it's like there's not insufficient, or I mean, there is insufficient data to kind of compare this to addiction, but it is, and
Hmm.
we talk about it now and like with our phones and again with food and what I like we're so used to in our day and age immediate satisfaction, right? Like no matter I'm all the time like, well, let's Google it. We'll just figure it out. Like we'll just figure it out right now. We're used to that quick, like, and that again with food for me is like, all right, this makes me feel better. I'm gonna have a
Mhm.
Yeah.
cookie. Makes me feel better.
A quick happy fix.
Right.
And
Instant gratification.
yeah, exactly.
Instant gratification. Yes,
And with
exactly.
seeing the studies of the dopamine, it's exactly you get what you put in. So you eat a sleeve of cookies and it goes up, but it immediately goes away.
Yeah.
You do meth, it immediately goes away. But if you go for a run, then it stays up longer. If
Hmm.
you once we write this 10-page paper and get an A on it, it's like, oh, we feel good for a longer period of time. So it's like that's the drug, that's the eating disorder, that's a lot of the payoff is high, but the bottom drops right out of it once the cookies are gone.
Yeah.
Versus
And then you have to keep upping it like any reward system.
right,
Like the
yeah,
first time you do it, 3 cookies might have made you happy. But to get the same level of happiness, now the next time you might have to have 5 cookies.
yeah, and like with drugs, now you're just doing them not to feel sad. You're not even getting a rush. You're just getting back to your baseline.
Yeah, you're getting the baseline
Thank
threshold
Versus
of
getting,
dopamine.
yeah, you're just trying not to feel bad versus feeling good. So yeah, it's
Yeah.
like the thing we all do though. It's always human nature. It's like we know eating broccoli is good, but it's a lot easier to go
It
drink
doesn't
5
taste
liters
as good.
Yeah.
Right.
of
It
broccoli.
doesn't taste as good.
Like, yeah,
Broccoli doesn't make me happy.
right. But in the
Stuffing on the
long term,
scale
it
the
does.
next day
In
might
the
make you
long run.
happy.
In the long run.
In that's
Not
the thing.
unless you have the right dipping ranch.
No.
Hidden Valley. It's Hidden Valley. But yeah, no, so this was a really hard one for me because I have struggled with it myself. And I don't it's the persistent use of that is kind of my crutch, you know what I mean? Like and again, I had weight loss surgery and I know and I have a routine that I follow, but when stuff hits the fan, that's what I fall back on.
Hmm.
So how is it not closely correlated to addiction? This has been a struggle for me, this one.
I think you're right on. I mean, it is closely related to it. The thing that throws me off about this is that to come up with mild, moderate, severe, and extreme you use a BMI, which they kind of went away from even using
Which is
BMI as
not
like a
an
health indicator.
accurate, yeah.
So I'm kind of surprised at the DSM. And I also know people that, which they're probably a separate diagnosis, but people that binge eat and throw up, like my sister did it. And she was never underweight. Like she was always fighting her weight. And I don't know if that goes into bulimia
Hmm.
or just like a binge eating disorder. But like to meet the anorexia disorder, you have to be like 17 BMI, which is like a stick. And
Hmm.
then you get into like, I don't even want to go down this rabbit hole. But for women in the military, the BMI is 20%. So you think of a woman that's trying to stay under 20%, you could easily fall into the 17, 18, just trying to make weight.
Very wild. Yeah, I agree with you on that. BMI is no, we should not pay attention to that anymore.
But yeah, I thought that was kind of odd.
It is. Anyway, for our purpose of time, should we move on to the eliminating and then the sleep wake? Because I could
Yes.
stay on this all night. I just want
Yeah, I mean, we got the
Yeah.
eating disorders, anorexia, bulimia, pica, which
Yeah.
was a new one for me, and then binge eating. I mean, once you figure out there's some level
Which
of eating disorder, I think you can probably dive into the DSM-5. I think you can get into like, okay, this is not a normal pattern of.
Can I say this though? Like, part of it is cultural, right? So, like, I'm
Hmm.
from the South, and my family, like, if you craved something, they would just be like, "Well, you just are missing this mineral," right? So, like, when I was a kid, I wanted to eat ashes, and they're like, "She's just missing a mineral." Like, that's a culture. No, it's not. That's not.
Yeah, but like, yeah, it's like, yeah, that's right. Because as a BCBA, like, you can't address pica until they've seen a doctor, because you have to rule out, like, so if, even as a therapist, I would imagine like ethically it's the same. Like, you can't rule, like, if someone's eating like that, like ashes, or we have kids a lot that pica, they eat like paper out of the trash, and then we can't rush in and immediately go, well, we got to put them on a schedule to make them stop doing that. It's like, no, they have to see a doctor immediately, because it could be a lack of what you're saying.
Nutrient
And oftentimes it's
yeah.
not, different, like, psychological thing. But yeah, that's the one too that, like I said, you have to know that you can't just rush in and try to eliminate that behavior without getting to the medical causes first.
Thank you. I appreciate that I'm not.
Yeah.
So
Yeah,
going into elimination disorders, we got enuresis. I think is how you say that. Anybody got a better pronunciation? Patient just repeatedly urinates into clothing and bedding. Of course, I think there's like probably an age onset of this where.
Age 5 or older.
What is it?
5 or older.
Yeah, but I think like there's also probably a cap on it. Like I have elderly patients who have zero bladder control. I don't think that would fall into like a psychological diagnosis.
No.
Encopresis. Anybody else know? And it's the same thing, only defecating. Um, and
This would
then,
be for children, yeah, adolescents.
so is it mainly just for children?
I think so. Typically diagnosed in childhood or adolescence. So I would say maybe it's like really, really bad when they're younger. I don't know. I feel like would that be something that goes into them, that goes with them into adulthood also if they have this type of disorder or
Does this go into the sneaky pee of chapter?
Nah.
Sorta.
I mean, we could. I mean,
I
that might
don't
be a
know
whole
what we
thing. But
diagnose her as, but
one thing I will get into off of this is just, and I don't, and this book doesn't give it, but as a clinician, I would advise you to look into it. Is a lot of sexual abuse. Uh, Kids that I've had would have pee in the bed or defecating, and I don't know if it was like a cry for help or just like part of their trauma and how they
hmm
responded. But it's a
Child
pretty
sex.
Yeah.
tightly wound correlation that sexual trauma would be followed by like bedwetting. So that, like Dantley said, like working in a school, um, if a kid's constantly bedwetting or like would be bedwetting, like I had a whole caseload of 3 girls who were molested by their dad, and all of them had like bedwetting issues. Uh, so I think some of that can be an indicator if you're working with adolescents or youth that there might be sexual trauma involved.
Yeah, I know. I've experienced that a bit in my job, and it's the keys. I know a lot of the key factors we look at were they already potty trained before. If it's a 6-year-old that
Yeah.
hasn't really had a full grasp on that, it may not be sexual. But if it's that, like a fourth or fifth grader, that's obviously. And then when you read the roots of that, it's really saddening because it can be like they become so traumatized that they just lose all control of their genital. Like they almost disassociate from their own genitals,
Yeah.
and then they lose control
hmm
to be able to hold their bladder because
Yeah.
it's
Yeah.
like I don't even want to think about that thing because all the trauma I've experienced. So then they start bedwetting because of that. That can be, that obviously you'd want to do your due diligence in that, but that can be a reason why they bedwet after
Yeah.
abuse.
And if they've experienced like severe neglect, they might not know how to, when to use the bathroom or how to use the bathroom. So they use the bathroom on themselves. They weren't taught basic self-care skills. Because
Yep.
we had a kid on our adolescent unit that was very similar with that type of situation. They um, basically were not taught how to use the bathroom.
For time's sake, we'll move on, but I could spend time on that. I'm
Same.
really kind of surprised DSM-5 doesn't link it back to like a sexual trauma, or maybe it does, and the version I'm on right now doesn't.
Yeah.
Um, so what we'll probably run more into is sleeping disorders, and we had a video on this week. Uh, Insomnia. I mean, I think most people know what that is.
Mm-hmm.
Um, I think one of the things that you got to get into the fine print or the D's of insomnia, which is it's 3+ nights a week for 3+ months. Um, so a lot of these are just like checking the box, like, and then you can have like episodic, persistent, and recurrent. So these things are just like, what's the different codes you're going to try to find if they're complaining about not being able to sleep? Uh, Hypersomnolence is like if they have 7+ hours of sleep. I think I skipped one, but they're always still tired. I have a client that has this right now.
Yeah. That
And
would
I
be.
think a lot of times it's pretty easy to like roll this into like depression, especially if I already
Hmm.
come with a depression. But then
Yeah.
when does it like become something different?
Yeah. Also, like, I have narcolepsy, so I can kind of relate with the, like, if I didn't have a diagnosis, then I would probably be pretty depressed because I am not able to stay awake. I feel bad about myself because I'm not able to stay awake. I'm not able to hold a job type thing. So I'm sure, like, um, under diagnosis or not having a diagnosis, if like the person needs one, could lead to depression and things like that.
Well, and so I'll add to that, like my experience has been, and Chris and I were on here before you guys, and I was talking about I had a brain injury. I had a motorcycle accident and I had a brain injury. And part of that has been disrupted sleep cycle, right? And so some of that comes from this brain injury that I sustained. And part of it comes from like anxiety and some ADHD that I've, again, from this accident that I've abstained. But how do you separate it? I think that's the thing for me. It's like, how do you separate there's so much overlap in it. It's like, what's causing what? How do you separate those things and either treat in a counseling situation or medicate for these symptoms that are happening? So I went like a little bit over a year being medicated with sleep medicine. But it did not keep me asleep. None of that. But I went that whole time of your brain just needs to rest. Your brain needs to rest. Your brain needs to rest. With no, there was nothing else. It was just take this medicine and go to sleep, right? Versus let's work on your cognitive skill, your behavior, like all of these things that need to come with it, if that makes sense.
Yeah. Like, what are your thought patterns around going to bed?
Correct. Yeah. Like, tell us more about what's happening. It was just like, oh, you can't sleep, take medicine. Here, we'll up it, we'll up it, we'll up it. Here's 100 milligrams of sleep medication. We'll up it. And it's like that. But there's so much more going on here.
So Aiden kind of touched on it, and we're getting close on time, so we can probably finish the DSM-5 on narcolepsy. I mean, you go into a whole host of other sleep, non-REM sleep, and all that stuff. One of the things that stuck out on narcolepsy is the word, uh, which is cataplexy.
Mm-hmm.
Anybody know what that is? That
Yeah.
just kind of like zoning out?
No, I have cataplexy. Like an involuntary loss of like muscle. Your muscles just become like weak. It can be like as severe as like if you start laughing, your knees might buckle because
Yeah.
like you like that muscle.
My grandmother has that. I mean, I'm always really goofy, like making jokes and stuff. And anytime I make her laugh, she will just pass out.
You know, and
That's a
it's
symptom of narcolepsy.
It's like any emotion. Like if she gets really, really emotional, like sad, like when my niece was born and they put her in the viewing window, my grandmother, she passed out. Um, yeah. It's and she's not allowed to drive either because I mean she obviously if she's
I can't drive. I don't know how to drive either.
yeah, if
Um,
she's experiencing that while she's driving, then
yeah.
not a good not a good situation.
So
It
diving
can
out
be.
of the DSM-5 now and into the like treatment planning. I texted my boss. I'm like, I can't believe UK's charging me to write treatment plans because I have to write these like every day. But I think one of the things, like, I don't know, you're in the field. I think most of us are in the field. Denise has a pretty good understanding, but not in the field. But I think mainly what I can take away from chapter 4 is what we call like the golden thread. Like the
Yep.
diagnosis has to meet like the goals and has to meet the objectives. But you don't come up with the goals typically. I mean, when you're writing a treatment plan and they come up with the inverted triangle and you're talking about like, well, here's the diagnostic criteria and here's the psychological problems that we can identify. Here's the things you're complaining about or your main complaints, then you would hope the person would have like reasonable goals towards them. But usually as a clinician, you never come up with the goals.
No.
I mean, you can
Yeah.
be like, hey, you've been complaining about you never get out of the house. Do you have like a goal for that or?
Take a walk. Yeah, whenever I used to be a case manager, so we had to do our treatment plans, which were different from the counselor's treatment plans, but um I always just kind of discuss with my patients, you know, what they're struggling with and then how they kind of wanted to achieve it, achieve that issue that they're having. And they would just come up with their own goals and then we would make it measurable. So that's like, I would like to have this within the next month.
Yep.
Smart goals.
So
In
forth.
the corporate world, it's smart goals.
Yeah,
One thing I
I've
think the
heard of
book
that.
brings up that's a very good point is like if a client comes to you, like you have like behavioral goals, but then you have things that jump out. Like if they're suicidal, obviously your first goal is like safety. Like if
Mm.
they're suicidal, there's no sense in working on like, well, we better get some exercise or like, like some goals take some precedence whenever you're involved in a case. My struggle is we don't get to do the intakes typically now. So then I'm handed a case with a diagnosis and like an intake summary, but I didn't have the conversation. And then I'm basing a treatment plan off of somebody else's information.
Right.
So then you got to kind of weave that. Ideally, you would be the one doing the intake, or at least being in on the intake, and then you would be, able to find out the problem areas from that. Like Denise said, like measurable goals. And like our treatment plans, if our goals aren't put in like our client's own words, they get kicked back. Like our
Yeah, we
supervisor
have
will
to
be
put it
like,
in quotations.
yeah, you have to put it in quotation. I think that's a CARF standard actually, so that's not
Mm-hmm.
going away anytime soon.
No.
So that's wild because as someone who's only received therapy and never been the person on that end of it, nobody's ever asked me my goals or
Really.
no,
But sometimes
never.
you do it like nonchalantly, like, hey,
Yeah.
how would you say that we go like
No, and like
we
I
agree
don't
to meet 2 times a week and you can kind of talk about your thoughts.
care.
But
But like
usually I have them ask them like point blank and then I just write down like, hey, you said you have this problem with,
we're gonna
let's
do
go into our last one.
yeah.
Like, you said you can't sleep. Like, what goal would you have for that? And they might be like, I would just like to get a good night's rest
One
4 nights a week or something. And then you write that down. And then you come up with an objective. It might not be 4 nights a week, but it might be like, what's the first step we can take to that? Let's say don't drink any caffeine after 5. That's a good objective towards being
There's
able to fall asleep, and like, so you take these like small measurable steps.
I don't know. I don't like going through I don't feel like I've ever received.
And the sad part about it is it might not be best practice, but it's probably because I know you said that you were private pay. Like we have to have these things or we don't get paid. It's like
Yeah,
we have to submit
Medicaid's like there.
insurance authorizations, so we have to have goals. So I know that I mean that shouldn't drive your
Well,
practice either way, but that's probably it. If you're paying out of pocket, then they're like, I don't have to submit anything to anyone.
Yeah,
and to the point of like our chapter 4, it's very much hinged on that of like
Mm-hmm.
what we have to write up or whatever, you know.
Well, it's a later assignment, so you're going to get a dose of it.
It is. It is. Yeah.
Um, can you hear me okay?
Yeah.
Yeah.
I thought it was interesting or like helpful when they pointed out in the chapter it was like, oh, the looking at the goals of treatment planning and the three different levels. There could be necessity, improvement, and then potentiality, and like the differences and like what those three goals were. That kind of helped me in my mind, like
Yeah.
that aspect.
That was kind of broken up. Somebody can explain to me what.
He was talking about in chapter 4 when it was necessity. Hang on, I gotta flip my pages here. Necessity, improvement, and then potentiality. Yeah. So
Oh,
it's
okay.
like, so they come to you and it's like, okay, we have this big picture of things, and now we got to break it up. What's the necessity? Like, what do we have to do to get them performing in life the way that they need to be
Yeah.
Yeah.
performing?
And that
And
goes into a lot of the diagnosis too, is like,
it does.
what's the major thing that's
Problem that you're having.
interrupting your process of your life?
Yeah.
Let's
Yeah.
focus on that.
Well, and to the treatment plan of it, of like, okay, what's our main target? All right, so you got to get, we need you to do X, Y, Z. I don't know. And then
Mhm.
there's improvement on the function, and then potentiality. So
Mm.
the bigger picture of things of like where we can get from now. Right, Aiden? Or
Yeah, that's what I was talking about.
Yeah,
yeah.
and see with the treatment plans that I used to do, we would list everything that they would have, what they were having issues with, and then when we would put beside it on if the patient wanted to work on it actively or if they wanted to kind of put it on the back burner, or if they, like we would let them choose if it was something that they wanted to work on like immediately, or if it was something that they kind of wanted to wait on and then you could come back to.
Mhm. That's
But
it.
what I started with the golden thread, like you do treatment plans, which turn into case notes because all these interventions they're talking about, you have to document. So then everything has to, the diagnosis has to meet the treatment plan, and then your case note has to show that you're working on something that goes all the way back to the diagnosis or one of the objectives or one of the problem areas. So, like, our treatment, when I start my case note, the treatment plan pops up, and I have to click what this intervention worked on, and then it allows me into the note, and then I have the place where I have to document some level of progress because Medicaid, if you're not making progress, they're like, okay, this is your 10th intervention with this person, and they're still in the same spot. Like, then why are we paying for this?
What
You're like, I can't fix that.
interface or what software do y'all use, Chris? Like what
Care
software?
Logic,
What is it?
Care Logic.
I
Yeah,
was just
that's what
curious.
I used.
Gotcha.
Yeah.
Hey guys, I love our discussion. We are at 7:55, so we went much longer than we tried to. Aiden, I know you have to go back to work. Um, can we go
A
on
lot of
and
material to get
end?
through.
Can we go on and
That's fine
end
with me.
the, go ahead.
Yeah, I think we're good to end. I think we covered everything.
Yeah.
Okay. Anybody have anything else to say? All right. You guys have a great night.
Are we
You
going to talk
guys
about
too.
the paper, or are we just
Oh,
going
hold
to?
on.
Stanley,
Are we going to talk about the paper, or are we just going to kind of?
okay, I'll stop the recording.